this video, we will be talking about shoulder fracture injury. But what is a shoulder fracture? A shoulder fracture is a break in one or more of the bones forming the shoulder joint, which are the clavicle, scapula, and proximal area of the humerus. It is one of the most flexible joints in the human body, allowing us to lift, reach, and move our arms freely.
Break the bony bump on the outer side of your upper arm bone, you won't just have pain. You can also have trouble moving your arm, and your shoulder may feel unstable. This type of injury is called a fracture of the greater tuberosity. It's usually caused by trauma, like a car accident or a fall. And if you have osteoporosis, a condition that leads to weak bones, your risk is higher. A doctor can treat it by putting your arm in a sling. But if the bones are out of place, it can involve surgery.
Here are the types of humeral head fracture.
This slide shows the patient history folder. The patient name is Rusdi. He is a 39-year-old male. He was diagnosed with a left proximal humerus fracture. Due to this injury, the patient experienced pain during shoulder movement as well as pain at rest. He also has reduced muscle strength and limited range of motion in his left shoulder. This complication affects his ability to perform daily activity and shoulder movement effectively.
In this evaluation phase for a shoulder fracture patient, we begin with a pain assessment using the 0 to 10 numeric rating scale. For our patient, Mr. Rusdi, the result is an 8 out of 10, indicating severe pain that significantly limits his movement and function. Next, we evaluate physical capacity. Using manual muscle testing (MMT), Mr. Rusdi scored a 3 out of 5, showing limited strength against gravity. We also assessed his range of motion to identify specific restrictions caused by the fracture and immobilization. Finally, we assess the patient's ability to perform activities of daily living or ADLs by using the Modified Barthel Index. Mr. Rusdi is currently fully dependent for bathing, grooming, and dressing. With a total score of 80 out of 100, our OT intervention will focus heavily on restoring his ability to perform these daily tasks.
Next, we have intervention. For surgical intervention, we have open reduction internal fixation. This is where bone fragments are realigned and fixed with plates or screws. It is used when fracture is repairable and bone quality is good.
An incision is made on the side or front of the arm to allow access to the side of the humerus. If the fracture has caused part of the humerus to shift, the bone is realigned. A metal plate is inserted and is positioned over the humerus. Surgical screws are inserted and are attached to the metal plate. This will hold the plate in place and stabilize the humerus.
The next surgical intervention is arthroplasty. Arthroplasty is a surgical replacement of the shoulder joint. It is used for severe or complex proximal humerus fracture. There are 3 types of arthroplasty: total shoulder arthroplasty, hemiarthroplasty, and reverse total shoulder arthroplasty. Next is non-surgical intervention. For the first non-surgical intervention is for pain management. A sling, splint, or brace is used to support the arm and keeps the bones aligned. The main goal are to reduce pain and discomfort of the patient.
The next intervention is strengthening exercise. This exercise focuses on strengthening the rotator cuff muscle because this muscle plays a key role in stabilizing the shoulder joint, especially after injury or surgery. Shoulder abduction is practiced because it is a functional movement needed for many daily activities such as reaching, dressing, and grooming. Light resistance bands are used to ensure the exercise is safe and controlled, preventing excessive strain while still promoting muscle strengthening. By incorporating daily task simulation, the patient is able to practice functional movements which help improve carryover into real-life activities. Next is ADL training. ADL training aims to improve independence by teaching compensatory strategies such as one-handed techniques and the use of adaptive aids. These interventions allow patients to perform self-care activities safely while minimizing stress on the injured shoulder. For bathing, a long-handled sponge is introduced to allow the patient to clean the affected site without excessive shoulder movement. This promotes safety, comfort, and proper hygiene while respecting movement restriction. Lastly, range of motion exercise. ROM exercise aim to prevent stiffness and improve shoulder mobility. Daily stretching and control movement help maintain flexibility and support functional recovery.
Moving on to our outcomes and final decision, we have achieved 3 key milestones. First, functional recovery. The patient achieved a Battle Index score of 100/100, indicating full independence in daily activities. We also observe a full range of motion and a significant pain reduction to VAS 1/10. Second, psychosocial participation. The patient has successfully returned to leisure activities like gardening and swimming, leading to improved mental well-being and confidence. Finally, the clinical decision. Since all rehabilitation goals are met, the patient is now clear for discharge. Our post-discharge plan includes a home exercise program, HEP, to ensure long-term stability and strength.
In conclusion, shoulder fracture can significantly affect a person's ability to perform daily activity due to pain, reduced range of motion, and muscle weakness. This limitation may interfere with basic activities such as dressing, bathing, and grooming. Occupational therapy plays an important role in helping the client regain functional independence by improving shoulder mobility, strength, and coordination. Through therapeutic exercise, activity modification, and adaptive techniques, OT help the client return to daily activity safely and improve overall quality of life.